Good morning, everyone. Thank you so much for having me. I'm really excited and honored to be here. And today I will be talking to you about the approach to the pediatric patient with recurrent infections. I know that this is a very common reason for referral to many of your practices, and a lot of the information that I'll be talking about today may be familiar to you, but one of my goals for this presentation is to really provide you with my approach to these patients and just kind of help you develop a framework, a systematic manner of evaluation. And so I will start off with 2 questions. I won't give you the answers yet. This is just to kind of pique your curiosity. The first case is a 3-year-old patient that is brought to the pediatrician's office due to concern for recurrent infections. She has had 4 viral respiratory tract infections in the past 2 months, and her parents are concerned because she's not in daycare. She really hasn't been to any indoor places due to COVID-19 concerns, yet she's still getting sick. And so her parents are concerned, and what are aspects of her clinical history that may be helpful. So this is actually my 3-year-old that I borrowed for this example, and we'll get to the answer at the end. The next question is infection with which of the following pathogens would not warrant an immunologic evaluation in a child. So you can look at the list of pathogens and which one would not make you concerned for an immunodeficiency. And we'll be talking about this in the next few slides. So here's our outline. I will start off by just defining what are inborn errors of immunity, what is normal, and then we'll talk about differential diagnosis that includes non-immunologic causes for recurrent infections. And then lastly, I will share with you what are features of infections that really make me concerned about an underlying immune deficiency. So you may have seen this newer term called inborn errors of immunity. That is just an overlying term that encompasses not only primary immunodeficiencies, but also immunodysregulatory conditions. At present, there are more than 450 genes that are identified that contribute to disorders of the immune system. So way back in 1970, the WHO formed a group with the aims of proposing a classification system for different immunodeficiencies. At that time, only 16 immunodeficiencies had been identified. And as this graph shows you, that number has significantly increased over the past several decades. One of the factors that has really contributed to this increase is the development of next generation sequencing, with which now we can identify specific monogenic causes for disorders associated with the immune system. And in 2017, that's when the shift happened between the term primary immunodeficiency to inborn errors of immunity. In this talk, I'll kind of use them interchangeably, but if you look at the literature, there's more of a trend of using the term inborn errors of immunity. One thing that I thought was interesting is this graph kind of just shows you the numbers till 2017. In 2019, the IUIS, which is the International Union of Immunologic Societies, at that point, they had identified 430 genes and put forward a consensus statement. But within a year, they had to update that consensus statement because they'd identified 26 more genes. And I think that just speaks to how rapidly this field is expanding and just how exciting it is to be in the world of immunology right now. So these inborn errors of immunity, as we can identify more genes, what we're finding out is that we really can diagnose more and more patients with underlying issues of immunity. And the prevalence in the United States is estimated to be 1 in 2,000 patients. So I would say that's pretty common. And some of the studies that are trying to look at, what is the frequency of what we're seeing in our clinics, estimate that up to 20% of patients seeking care in an immunology clinic may have an inborn error of immunity. This particular study, talking about Chicago Pride, this study was done by Benjamin Prince, who was a former Northwestern fellow. And they looked at 210 patients that were referred to their immunology clinic. And the reason for referral for 182 of those patients was concern for a primary immunodeficiency, and 30 of them were diagnosed with an immunodeficiency. So that puts it at about 20% of patients. And so when we're trying to figure out what category are our patients falling into, which patients are falling into that 20% that really do have an underlying cause versus the 80% that don't have an immunologic cause for their infections, how do we kind of approach that? One of the first steps is to understand that there is a physiologic immunodeficiency of immaturity. So this is different from transient hypogam. This is something that almost all newborns and young children have. We know that young children are susceptible to infections. This is why we take extra precautions with them. Even if you have a term healthy neonate, we know that these patients can be susceptible to particular pathogens. I really liked this paper by Slatter, where they went through specifically which arms of the immune system are affected and specifically how even a healthy neonate is really physiologically immunodeficient. So starting off with neutrophils, newborns have low bone marrow reserves and they have reduced neutrophil chemotaxis. There are studies dating back to the 1960s that describe that newborns have low complement level and function, and both the classical and alternative pathways are affected. We know that there's decreased cellular responses in newborns, and this can be due to poor responses to antigen. The neonatal naive T lymphocytes are difficult to stimulate. There's a decrease in CD40 ligand expression. And interestingly, there's a skewing towards Th2 away from Th1, and that may explain the susceptibility to intracellular bacteria such as Listeria or Salmonella. And lastly, we do know that newborns and younger children have issues with humoral responses. So maternal transmission of IgG occurs late in the third trimester. And then after the 3-month mark, when the maternal IgG is wearing off and the baby's IgG is about to really reach peak production, you can reach this physiologic nadir, and that can take place between months 3 to 6. Specifically, IgG2 subclass production is delayed, and this is why these babies can be susceptible to polysaccharide encapsulated organisms. Starting at age 2 months is really when we expect babies to start to produce IgG to protein conjugate vaccines, and this is really what informs our current vaccine schedule. And then just a note about IgA. In our clinic, very frequently we evaluate patients for IgA deficiency, and we reassure families that selective IgA deficiency, really that diagnosis can't be made until after the age of 4. IgA takes, it's the last immunoglobulin to reach normal levels, and some of my patients I've seen it take into adolescence or early adulthood. And we only get concerned if the IgA is completely undetectable. And so if the levels are borderline or somewhat low, then we wouldn't categorize that patient as selective IgA deficiency. So moving on to defining normal frequency. So this is a big question I know that we encounter. What is the normal number of infections that a child should be experiencing? Of course, all of this is it's a little bit hard to say what is normal during this period of time that we're living through, where there is so much increased precautions, and especially when there was increased masking and hand hygiene taking place in daycare. I think the number of normal, all of our set point for normal probably was different at that time. But in general, normal frequency of respiratory infections is defined as 6 infections per year. each infection can last 1 to 2 weeks. This number is slightly higher in children who attend daycare, and so it can be up to 9 to 10 infections per year. And if each one lasts 2 weeks, then if it feels like the child is sick all the time, they probably are sick all the time. And what we tell families is that a quarter to half of the year, the child could either be getting sick or getting over an illness. Then the next question is, what are recurrent respiratory tract infections? So when is it outside of the norm of just, normal frequency of infections? It's estimated that 10 to 20% of the population has recurrent respiratory tract infections, but it was really hard for me to find consensus regarding what is categorized as recurrent respiratory tract infection, because a lot of different groups have different ways that they define this condition. But in general, it would be more than the 6 to 9 infections a year that we see in the general population. The risk factors that have been identified with recurrent respiratory tract infections are older siblings, daycare attendance, poor nutrition, cigarette smoke, and overcrowded living conditions. So here's another slide kind of talking more about how do we define normal. And what I wanted to highlight in this slide was that common things are common. And I wanted to share a story. So when I was a second-year fellow, I was in San Francisco, and it was a rare weekend when both my husband and I didn't have fellowship responsibilities, so we thought we would drive down from San Francisco to Los Angeles. And I don't know how many of you guys have done that beautiful Pacific Coast Highway drive. It's gorgeous, but it is a little bit hilly. And we had our 1-year-old in the car at that time, and about midway during the drive, he started vomiting. And so the allergist in me was like rapidly trying to think back, when was his last meal? Is this IgE versus FPIES? My husband, who's an oncologist, was going through his own differential diagnosis of what this could mean. Thankfully, we had my mom in the back seat, and she said, "You guys, this is a baby. You're driving up and down these mountains. This is motion sickness, which is very common in children." And I often think about this story because I think sometimes we just get so much in the weeds and we just love entertaining these rare diagnoses that sometimes we just forget that most of the patients that we see, they're not going to have an inborn error of immunity. The majority of our patients will have normal immune systems, and there's probably other causes for their recurrent infections. So here is a study by Peters that showed their center's experience. They had about 1,800 patients that were referred to them for any type of respiratory complaint, and 208 of those patients had recurrent respiratory tract infections. And in their study, they found that 64% of those patients didn't have any underlying etiology at all. And the remainder of those patients had issues such as anemia, asthma, atopic disease, and adenoid hypertrophy. And we'll be talking about those in the next few slides. And the majority of these patients, the pediatricians just adopted a wait and watch approach, and that seemed to work out just fine for those patients. And so when we're kind of talking about who are the kids that we can adopt this wait and watch approach for, and who are the kids that we really need to pursue more testing, one of the factors that this group found was, what does the growth look like? Is the child staying on their growth curve? How are they responding to treatment? Are these children requiring back-to-back different types of antibiotics and different multiple courses of antibiotics or IV antibiotics to clear the infection? And then lastly, what do these kids look like in the interim when they get over the illness? So the child that I mentioned, the daycare going child that can have up to 9 illnesses a year, all of those kids, when they get over their illness and before their next illness, they're back to their baseline. They're active, healthy, growing, and developing well. And so these are really important factors that can help us identify which children are healthy and don't require additional evaluation. just one quick note about this study. I thought it was interesting that they identified anemia in 7 of those patients. It's really unclear how anemia leads to increased frequency of infection, but there actually is a lot of literature in support of that. What's interesting is that if you replete the iron with iron supplementation, it doesn't always seem to correct the recurrent infections. So I think that's an area that we still don't understand too well. We will talk about atypy in the next few slides, as well as the gastroesophageal reflux. 57% of these patients had passive exposure to smoking. And I think that's another reminder for us to ask these families when you're evaluating these children if there is exposure to secondhand smoke in the home. So now we'll start talking about some non-immune differential diagnoses. And so these are all the conditions that can contribute to recurrent infections in children. And one of the most common contributory factors is atypy. So 30% of children with recurrent respiratory tract infections have atopic disease. And we've seen this all the time in our clinics. The kids that come in with recurrent runny noses, it's so hard to tell, are these really back-to-back viral illnesses, or are these or is this atopic disease? And I know as allergists, we have tools such as skin testing to look for environmental allergens and response to antihistamines and things like that that can kind of help differentiate whether this is atypy or back-to-back infections. Children with atopic diseases can develop coughing and wheezing following respiratory infections, and this presentation can sometimes be labeled or misdiagnosed as pneumonia or bronchitis. And so in our clinic, whenever we get a history of, oh, my child has had this many number of pneumonias, we really push a little bit further and ask if these are chest x-ray proven pneumonias, because a lot of these children will just have a viral trigger and it will exacerbate their asthma, and someone may do imaging that shows kind of non-specific chest x-ray findings and then label that child with a pneumonia. And what we're really looking for is like lobar consolidation concerning for a bacterial pneumonia. We do know that children with atopic disease are at higher risk of developing bacterial superinfections such as sinusitis, otitis, and the increased susceptibility to infection is due to a few different factors. It's thought that the pathogens themselves can adhere to the inflamed respiratory epithelium. There's increased mucosal permeability, and then there is this localized altered immune response to certain viral and bacterial pathogens. And so these are some reasons why children with atopic disease can be more predisposed to getting infections. And then one note that I wanted to add is we do know that there is this overlap of atypy and immunodeficiency. So let's say you see a child with recurrent infections, you identify that a lot of their symptoms are due to IgE-mediated disease. That doesn't necessarily rule out immunodeficiency, because there is a growing list of immunodeficiencies that have been identified where the patient can present with errors in immunity as well as atypy. Those are extremely rare, but I just wanted to remind you of that. In terms of gastroesophageal reflux, so 5% of patients with recurrent respiratory tract infections will actually have reflux as the underlying etiology. And there was a study from 2010 that looked at 200 patients, and that study suggested that when you treat the reflux with medications like PPIs, then the frequency of infections also improves. And then lastly, my approach to patients with recurrent infections is this a host issue, which for most of our patients that is going to be the issue, or is it a pathogen issue? Is the pathogen itself so virulent that any host is going to make them that sick? And so that can be due to either the organism itself being a resistant organism. So if someone has MRSA or multi-drug resistant Mycobacterium tuberculosis, then that really is the pathogen itself, not the host, that can lead to the severity of infection. And then there are some children that are in an environment where they're stuck in a cycle of continuous reinfection, and that can be due to contaminated water supply, a chronically infected pet. And one thing that we actually always have to consider is deliberate infection in the form of Munchausen syndrome by proxy. And so especially if you're seeing the same pathogen over and over, then that can kind of raise suspicion for this being either a resistant organism or a continuous cycle of reinfection. Moving on to other non-immune differential diagnosis. So one of the questions that I like to ask my medical students is, what is the #1 cause of immunodeficiency worldwide? And because they're first-year med students, they'll put things like X-linked SCID or hyper-IgM syndrome, and I have to remind them these are exceedingly rare diagnoses. The #1 cause is actually malnutrition, and it's 3 million children under the age of 5 die from malnutrition every year, and that accounts for 45% of all child mortality. So it's just a really humbling number to remember that is the #1 cause of immunodeficiency, and it is preventable. Other conditions that lead to a secondary immunodeficiency include HIV, and then we always have to remember to ask about any past or current medication because the immunodeficiency could be iatrogenic. So it could be immunosuppressant or immunomodulatory treatment. And you can kind of work backwards. So depending on the medication they're on and the mechanism of action, that can kind of help you determine the susceptibility to specific infection. In our practice, we see a lot of patients with cardiac disease. So 10% of kids with recurrent infections will have a chronic disease like underlying cardiac disease that can predispose them to recurrent infections. And so many of our patients that we see, especially kids who end up having to need a cardiac transplant, we will perform an immune evaluation to better understand, is it just the cardiac disease itself that's making them predisposed, or is there also a concurrent immune issue? And now moving on to physical and anatomic issues. So about a month ago, I saw a 11-month-old that had recurrent orbital cellulitis, and it was actually a pretty severe presentation. He had recurrent episodes always in the left eye, similar pathogens every single time, but severe enough to require frequent hospitalization and IV antibiotics. And because the cellulitis was always localized to the one side, there was a high concern for an anatomic defect, and with additional imaging, they were actually able to identify that there was a bony defect between the eye and the sinuses, and so there was this easy transmission of pathogens into the eye, and so that was thought to be the reason for his recurrent orbital cellulitis. Other anatomic issues like vesicoureteral reflux can cause conditions like recurrent UTI. The picture here demonstrates adenoid hypertrophy, and so if a patient has that, that can kind of set up the perfect mucosal milieu for pathogens to set up shop and cause recurrent infections. A note about cystic fibrosis. So in 2008, Illinois adopted the cystic fibrosis screen on the newborn screen. And I think whenever we have conditions on the newborn screen, then sometimes we kind of get falsely reassured that, oh, we can completely rule out this condition. I mean, we see that for SCID as well, that once SCID became part of the newborn screen, we just kind of just say, oh, there's no way this child can have this condition. They pass their newborn screen. I want to remind you guys that just because a baby passes their CF screen, their cystic fibrosis screen, that does not mean that that test is 100% sensitive. So the way that cystic fibrosis screening is done in Illinois is that first, they will look at the level of immunoreactive trypsinogen on the dried blood spot, and if that number is abnormal, then they will do testing for 1 or 2 copies of the CFTR genes. or mutations in the CFTR gene. And so if for whatever reason the initial trypsinogen level is not abnormal, that will not prompt the second test. And so that can lead to false negative CF newborn screen. The sensitivity of the CF screen is estimated to be somewhere between 87% to 97%. And so there are children that will be missed on the CF newborn screen, and for that reason, we have to keep our index of suspicion high in a patient with recurrent infections. Primary ciliary dyskinesia, eustachian tube dysfunction are also other conditions that we need to think about when you're seeing a patient with recurrent sinopulmonary infections. And then also conditions like eczema, where you have a disrupted epithelial tissue, epithelial barrier, and foreign body presence, which happens in young children. All of these things are anatomic reasons for recurrent infections. One of the hallmarks for anatomic reasons will again be the presence of infection in that particular location. So other organ systems won't be involved, and you'll see likely similar pathogens, and that similar anatomic area will be affected. So when should we start considering immune-related issues leading to recurrent infections? What I put up here is the 10 warning signs of primary immunodeficiency put forth by the Jeffrey Modell Foundation. I find this to be a good introduction. It just kind of gets people thinking about what's the frequency and severity of infections, what type of infections should we be concerned about. But what I'll really do in the next few slides is go through all of these warning signs in a little bit more detail. So when should we start looking for zebras? As I had mentioned, majority of patients that come into our immunology clinic, majority of them will not have an underlying immune deficiency. Many of them will have no identifiable cause for their recurrent infections. Some of them will have non-immune related cause for their infections, but about 10 to 20% of the patients that are referred to us will have an underlying inborn error of immunity. And so what should really raise your suspicion for that? For me, one of the biggest things is age of presentation. There are some immunodeficiencies that present very early on and have a very severe phenotype. And so for me, one of the biggest factors is age of presentation and type of infection. So in the neonatal period, if there's delayed separation of the cord, perianal ulcers, ampulitis, erythroderma, these symptoms can be associated with severe immunodeficiencies like Omenn syndrome, SCID, leukocyte adhesion defect. If you have a baby with cardiac defects and other syndromic features, then the concern for things like DeGeorge syndrome is high. And so in the neonatal period, these are kind of the things that I'm looking for. Cellular defects like SCID will present before 6 months of age. And so these children will have infections typically before 6 months. Between 6 months to 5 years is really when you'll start to see antibody and complement defects. You can see late presentation of combined immunodeficiency in this time period. And then also, sadly, this is when issues associated with DNA repair defects like ataxia telangiectasia will present. And so you'll have a baby that looked healthy at birth, had a normal newborn screen, and then after probably their second birthday starts to have trouble walking. Over 5 years of age is really when we start to see issues with humoral immunodeficiency. So moving on, another factor that I consider is what is the pathogen involved. There are some pathogens where just one infection with that one pathogen is enough to really raise suspicion. There are other infections where it's the recurrent aspect of the infection is what really raises concern. So the sentinel infections, where you just need that one infection with that pathogen, would be things like PJP, Burkholderia cepacia, and some would argue even one episode of HSV encephalitis, but really if you more than one episode of either HSV encephalitis or Neisseria meningitis, then those can raise concern. Other pathogens that are concerning are disseminated atypical mycobacterial infection, invasive staph or strep, fungal abscesses, HHV infections, and enteroviral infections, which we see in patients with XLA or CVID. So next we will move through organ-specific complications that can raise concern for PID. So starting with the respiratory tract. As I had mentioned, recurrent respiratory infections are so common in young children, but these features are really what get me worried. So one of them would be persistent or recurrent bronchiolitis in infancy. So not just one episode of RSV bronchiolitis, but if they're developing recurrent bronchiolitis, sometimes with different pathogens, that can be worrisome. Interstitial pneumonia, PJP, recurrent cyanobacterial infections, staph lung abscess with pneumatocele. We see that in patients with hyper IgE syndrome, and a fungal pneumonia. Those are aspects of pulmonary infections that would be concerning. With the GI tract, one of the biggest things that we look for is the patient's growth and development, and if there is concern for failure to thrive. We see failure to thrive in many, many patients with inborn errors of immunity, and this can be due to a couple reasons. Number one, it can just be that there is malabsorption that's taking place because their underlying immune issue is also causing GI tract inflammation. And the other reason can be that due to the recurrent infections, their caloric expenditure is directed towards fighting off the infections, and they're not really able to use those calories towards growth and development. And so that's why one of the things that we look at very carefully in our clinic is the growth curve for that patient. We are starting to evaluate almost every single patient with very early onset IBD in our clinic. And the reason is because there are more than 60 plus monogenic causes that have been identified with very early onset IBD. So as you may remember, inflammatory bowel disease has a bimodal peak. The first peak is between ages 15 to 29. And then the second peak is in the 40s to 50s. And so there are some children that will develop IBD in adolescence. About 25% of patients will develop IBD in childhood. But when we start to get concerned is when the IBD presents early on. And so there's different categories depending on the age of onset. There is neonatal IBD, which occurs within the first 28 days of life. Then there's infantile IBD, which develops before the second year of life. So thankfully, the neonatal and infantile IBD only accounts for 1% of pediatric IBD. What we see more commonly is the very early onset IBD, which presents before 6 years of age. And for all of these patients, we perform immune evaluation to look to see if there is an underlying immune issue like chronic granulomatous disease or XLP that could be presenting both with the GI disease but possibly with an immunodeficiency. Other organ-specific complications that we look for are hepatic abscesses, exocrine pancreatic insufficiency, and then specific complications. So for example, hyper IgM patients will develop Cryptosporidium parvum associated sclerosing cholangitis. And so if we see these kind of complications, then that really raises concern for specific inborn error in immunity. Some of our patients can have dermatologic manifestations. So we all take care of patients with eczema. And in our pediatric immunology clinic, we get referrals for young babies with severe eczema. And the question is, can this be due to an underlying immune issue? And sometimes that can be a little bit hard to answer. The patient can have diffuse atopic dermatitis. Their IgE can be 10, 20, 30,000. And so people are sometimes concerned about conditions like hyper IgE syndrome. One of the things that I really ask about is what is the age of onset? So even the worst cases of eczema really should not present before the first month of life. And if you get a history that the baby had a severe eczematous rash or an exfoliative rash or an erythrodermic rash at birth, that raises concern for an immune deficiency. So there's specific skin conditions that can be part of specific immune deficiencies. So erythroderma can be part of Netherton syndrome. Some of our patients who have issues with the Th17 pathway can have issues with mucosal candidiasis. Oculocutaneous albinism is seen in patients with Chidiac Higashi, and ataxia telangiectasia patients can have increasing number of telangiectasias as they get older. And so one of the other things I look at is, are these, so for example, for the baby with severe eczema, if the skin is the only organ system involved and you're not really getting a history of recurrent infections or issues with their bone, and there's not concerning pathogens involved, then I think it's safe to say that this is just really severe eczema and let's monitor the response to therapy, versus if you're seeing derm manifestation along with pulmonary and GI, when there's multi-organ involvement, then that really increases my underlying suspicion. So moving on to neurologic, this is probably an area where we know the least, just about the overlap between the nervous system and the immune system. We do know that many of our patients who have genetic syndromes, like DiGeorge syndrome, the patients will present with neurodevelopmental delay. I didn't put this on here, but a number that surprises me every time I come across it is 25% of patients with DiGeorge syndrome will develop schizophrenia. That's just a really dramatic number. And so these are things that we should be looking at. And there are a lot of patients that can have DiGeorge that are not diagnosed. Because the immunologic phenotype might be mild, their cardiac phenotype might be mild, and it's only when they have a child that carries the same mutation and has DiGeorge and maybe has a more pronounced immune issue, that's when you identify other family members. Most of DiGeorge is de novo, but a small percent, around 7%, is familial. So I think that's why it's kind of important to keep track of how our patients are doing from a neurodevelopmental path, from a neurodevelopmental standpoint, but then also get an assessment of how are the other family members. So a question that I'll ask families are, how did you do in school? Did you ever need extra support? Were you able to finish high school or college? Other neurologic complications that we'll see are unsteady gait, as in ataxia telangiectasia, microcephaly, which can be part of the syndromes associated with SCID. And then, as I had mentioned, issues with humoral immunodeficiency can make a patient predisposed to enteroviral meningitis. Moving on to hematologic complications, this is a really big area, and for this reason, in 2019, we had started an immunoheme clinic at Lurie Children's. Unfortunately, it's currently on pause because my heme counterpart ended up moving to a different institution, but we're hoping to restart this clinic. The reason why we had this clinic was because we were finding that a lot of our patients who had hematologic issues, especially things like autoimmune cytopenias, a large number of them had associated inborn errors of immunity. So things that should trigger an immune evaluation are primary HLH, meaning that there is no underlying malignancy or other trigger for the HLH, and also HLH if it presents very early on in life, neutropenia that's persistent, autoimmune cytopenias, especially Evans syndrome, and myelodysplasia. So just a note about Evans syndrome. Evans syndrome occurs when there is when there are two autoimmune cytopenias. Most of the time it includes an autoimmune hemolytic anemia, and then that is associated with neutropenia or ITP. And there was a study that came out probably 3 or 4 years ago now, published in Blood, that showed that 65% of pediatric patients with Evans syndrome will have an identifiable monogenic cause for their condition, which is a pretty dramatic number. And so for every patient in our institution who has Evans syndrome, we will perform a pretty thorough immune evaluation, and frequently we'll do genetic testing. And just an example of why the genetic testing can be helpful. So I saw a patient with Evans syndrome in our immunoheme clinic. We were able to identify a STAT3 gain-of-function mutation, which explained her cytopenias, but also she had lymphopenia and persistent lymphadenopathy. And knowing that that was her specific defect, we were able to pick a specific immunomodulatory medication. So instead of just throwing general steroids at her, we picked a JAK inhibitor, just knowing specifically that it's the STAT3 pathway that's affected. So moving on to the skeletal system, you can see short limb dwarfism associated with immunodeficiency. And so that can be things like cartilage hair hypoplasia. ADA SCID will present with rib cupping, and that's the picture that you see. Our patients with immunodeficiency can either have hypodense bones, such as what happens in hyper IgE syndrome, or hyperdense bones, such as what happens in osteopetrosis. And then this term sounds so fancy, delayed primary dental deciduation. Basically, it just means that your baby teeth don't fall out. And this happens in hyper IgE syndrome. And so a lot of times you'll get this history of patients telling you, my teeth didn't fall out. I needed to get an extraction for many of my teeth to allow for the adult teeth to come in. And so this other picture that you see demonstrates what the bones look like in infantile osteopetrosis. Lastly, the lymphoreticular system can be implicated in an immunodeficiency. We know a lot more about the adult CVID population and their increased risk of malignancy. What we're starting to learn more about is in the pediatric population. It has been established that pediatric patients with inborn errors of immunity are at higher risk of malignancy. These malignancies can include non-Hodgkin's lymphoma, hepatoma, EBV-associated lymphoma, and then other early or unusual malignancies can sometimes be a clue as to a defect in the immune system, or the cancer surveillance or apoptotic pathways are affected that can lead to the malignancy. So we've talked about which patients would raise concern. And once you evaluate these patients and identify elements from their history that are concerning for an underlying inborn error of immunity, the next step would be to proceed with an immune evaluation. And the way that we decide in our clinic what to proceed with is kind of starting off with which arm of the immune system are we worried about. So pretty much everyone gets a CBC with differential, but if we're worried about humoral immunodeficiency, then we look at immunoglobulins, B cell numbers, the vaccine responses. And just a quick note, when you're looking at immunoglobulin levels, make sure that they're age adjusted. There's several resources for that. At Lurie's, we actually, they age adjust for us, but you can use Harriet Lane or other resources to see really what is the range, the expected range for the immunoglobulins. If we're worried about cellular immunodeficiency, then we do lymphocyte flow cytometry and proliferation studies. You can do the NOI if you're worried about something like chronic granulomatous disease. We look at the CH50 or AH50 for complement deficiency. And then if you're worried about a specific defect in an immune pathway, such as CD40 ligand, then you can do functional testing, like a CD40 ligand expression assay. I have a picture of someone who's fishing here because I just want to warn people that we should try not to make this into a fishing expedition. And the shift in immunology really has been to push for early genetic testing. So instead of querying like specific immune pathways, and sometimes there's like a discordance in the genotype versus phenotype. Sometimes it's more cost effective, easier on the patient, and even more timely to proceed with the genetic testing early. And then we can usually use the functional testing to help us validate the finding from the genetic testing. So we will end the talk by going back to the audience response question. So this is my 3-year-old. She has been, when I wrote this question, she had been sick 4 times, and she's sick again. So we can make that 5 times on the past 2 months. She's not in daycare. I have kept her away from any indoor activities, and yet she has been sick back to back with all of these respiratory infections. And so if I bring her to you, what are aspects of her clinical history that you'd want to know about? And so majority of you guys identified all of the above. And we talked about how older siblings, I mean, that's the case for us. She has 2 older siblings that are bringing all sorts of germs home, and that's why she's been so sick. But other factors are atopy, parental smoking. Recall that I mentioned in that one study, 57% of kids with recurrent infections had exposure to secondhand smoke, nutritional status. All of these are factors that can lead to the recurrent infections. And then the next question is, which pathogen would not warrant an immunologic evaluation? We had talked about how PJP, Burkholderia are what we call sentinel infections, and then recurrent HSV encephalitis is concerning. The atypical Mycobacterium lymphadenitis, which is usually localized cervical lymphadenitis, occurs in immunocompetent kids. And this is just to emphasize the point that sometimes you want to look at, is this a disseminated infection or a localized infection? And sometimes that can make the difference.